Let me welcome you to the Michigan Medicine Health Disparities Community Action Network Forum. I and all of us really appreciate your interest and your participation in this very, very important initiative. The global COVID-19 pandemic not only devastated organizations and communities and families across the world, but it also revealed the terrible racial health disparities that have disproportionately impacted communities of color for centuries. We know and understand that COVID-19, along with many other diseases, does not discriminate by race. However, the social determinants of health and the racial inequities that leave underrepresented communities at higher risk has resulted in a much higher death rate and prevalence of COVID-19 in underrepresented populations. We are dedicated to being change makers and combating racial health disparities head on. I want to thank you for joining this fight and leading your expertise, your experience, and your passion to the collective work of this entire group and future subgroups. Michigan Medicine, along with our community partners and the state of Michigan, are working together to meet the needs of our local community and state. This forum is just the beginning. Thank you for your voice, for your dedication to improving equitable access to healthcare for all populations, and thank you for engaging, as we all are, in this critically important initiative. Dr. David Brown will follow me, and David and the group working together with him are true leaders in this area and has organized this symposium.
Thank you, Dr. Rangi, and welcome everyone to the first of a series of forums on health disparities. I'm David Brown. I'm the Associate Dean and Associate Vice President for Health Equity and Inclusion here at Michigan Medicine. This forum is completely virtual, and I want to thank all the organizers and all the participants. We were overwhelmed with your responses to our survey in a good way, and I will share those results soon. This first of many forums on health disparities, we'd like to start with a common understanding of the issues, discuss Michigan Medicine's role in contributing to healthcare disparities, understand the perceptions of Michigan Medicine and the surrounding communities of color, and agree upon first actions we can take to make progress toward eliminating healthcare disparities in our own community. For future forums, we would like to bring forward many of you and your expertise in this area to increase awareness, bring down the silos of efforts, and to learn how we can synergistically work together to eliminate healthcare disparities. Today, you will hear from a member of the Michigan Medicine Coronavirus Task Force, a community leader and reverend, hear a talk about how institutional racism contributes to disparities. Also we'll have a panel of University of Michigan and Michigan Medicine leaders, and then we'll conclude with a question and answer session with the executive leadership from Michigan Medicine. I was a member of the Community Action Task Force. There were two task forces, and I was on the small T task force, so I will go over the things that, that were important to us. Here on the slide, you can see the cases and the deaths. So the cases are in blue and the deaths are in the reddish color throughout the state of Michigan. And you can see for both of them that it's concentrated in Southeast Michigan, and it's especially concentrated in Detroit. There were a total of 839,590 positive diagnostic tests in the state of Michigan, with 64,413 total positive cases and 5,895. Can you go to the next slide? And then if we look at the cases by race on the left side in the blue, you can see that Caucasians is the highest number of cases, but African Americans in black is soon behind And if you look at the cases per million by race, you can see graphically how astonishingly African Americans were disproportionately affected by coronavirus, by having it even. And if you look to the right, you can see the number of deaths by race. And you see the Caucasians is the highest, and African Americans and Blacks are the second highest, is actually approaching that of the whites. And again, you can see the deaths per million disproportionately affects Blacks and African Americans. The absolute number of deaths that were African American, or actually a number of cases that were African American, were 18,345, and the absolute number of deaths was 2,248 in the state of Michigan. These are the latest data, and that represents 38%. Next slide. And so as part of the Community Action Task Force, our goals was to stop the bleed and to decrease the spread and the impact of COVID-19, especially on marginalized populations, the African American community. And a lot of the efforts were focused in Detroit because, as you saw on the initial map, it was completely Black because that's how dense it was. So our guiding principles were to protect public health by identifying and disrupting chains of transmission, draw on best practices from the federal guidelines and our state experience, listen to and partner with local communities and leverage the local health departments, create a seamless experience for the patients who need support with testing, tracing, and isolation. We realized that people had difficulty with access, difficulty with contact tracing, and not everyone was able to quarantine. So outside of Detroit, for example, there was a hotel that would allow people to quarantine if they were not able to, because sometimes people live, a lot of people, to one house or apartment. And we wanted to ensure that all solutions are attentive to racial and socioeconomic disparities across the state. Next slide. If you look online, you can see that a large part of the health of the COVID-19 cases have decreased, but we still worry about things in the future. And so our future steps is to have active linkage of patients to services and care, either related to COVID or not COVID, just general care, expand our mobile and walk-up testing for anyone who needs it, establish the high-risk populations with primary care providers, make resources available to people with limited English proficiency, ensure the services are not tied to existing barriers. Again, this is a policy or procedure. Those could be not having a primary care doctor and the need to show a state ID or driver's license. Now we're working on protecting access to water and energy. We need clean water to wash our hands. We need energy to lights and utilities to be able to get around and to use the internet, for example. And environmental issues, water, clean air, telemedicine access. We know that not everyone has internet access, and we know that not everyone has a smartphone or an iPad, and so phone visits may be very important. And we also know that historically, because of systemic racism, that there's a disproportionate number of African Americans in the prison system, and we also know that there's a lot of COVID positive cases there. So we're thinking about what can we do to change corrections reforms so that these people are not affected as well. Next slide. And so we launched on April 14th a survey, and we asked you the question, please indicate what you feel should be the first priority of Michigan Medicine or the state of Michigan to combat health disparities. And we had a total of 658 responses, and we themed them. And there are lots of comments that you use to support this, and don't have the time to go over those today. But you want to promote equitable care and access for all, improve health literacy, acquire the data, accurate data, Institute of Public Health response through community-based engagement in programs, and assess the underlying cause of the health disparities and systemic inequalities. And these are things we're interested in doing as well. Next slide. I want to let you know that as a program that we started last year through our Health Equity Leadership Weekend, which we started last year, we had Kamara Jones here as an invited speaker, and we started our discussion about institutional and systemic racism. We're going to continue with her work, even though she won't be the guest speaker this year. Next slide. When we start our health and healthcare disparities curriculum pilot. This was done through this ACGME, through a graduate medical education collaborative. This is a partnership with OHE, GME, and Quality Improvement. These residents will go through a 14-month curriculum, learning about social determinants of health, social needs, cultural humility, and they're all going to have to do a capstone project using QI techniques to evaluate disparities by race, ethnicity, and language, or real data. We realize that this needs to expand beyond the House officers, and it is our goal, and we're still a part of this collaborative, to have this information available to the entire entirety of Michigan medicine ultimately. Thank you. Next, I will have Dr. Matt Bolton. He's a faculty member at the School of Public Health. He will talk about the Michigan Coronavirus Task Force on Racial Disparities.
Thank you, David, for the invitation to participate in this important discussion today. I'll just say by way of a brief background that Governor Whitmer signed the executive order forming the Coronavirus Racial Disparities Task Force on April 20th earlier this year. The task force is chaired by Lieutenant Governor Gilchrist, and it's been generally charged with examining racial disparities in the impact of the COVID-19 pandemic and making recommendations to the governor, to Dr. Khaldun, who's the state's chief medical executive, and to the state health department itself with respect to interventions that have the potential to mitigate the disproportionate impact of the pandemic on populations of color. The primary areas the task force were asked to address, and this is a brief version, but include increasing transparency in reporting data with regard to inclusion of race and ethnicity variables, removing barriers to healthcare and mental health care access, reducing clinician bias in testing and treatment, mitigating environmental and other factors contributing to increased exposure of minority populations resulting in greater COVID-related morbidity and mortality, and finally, enhancing systems for supporting longer-term economic recovery and achieving sustained improvements in physical and mental health care beyond the pandemic. The task force was initially meeting online twice a week, but about a month ago, we went to a once-a-week schedule with the other meeting time used for subcommittee and work group meeting discussions. I should mention that the task force is required to adhere to all open meeting laws and regulations, including time allowances for public comment during our weekly meetings. Initially, the task force has been very much focused these first few weeks on boosting testing access and augmenting data reporting, particularly in Detroit, as you mentioned, David, which was the first work group formed at the direction of the Lieutenant Governor about 3 weeks after we got underway. The testing infrastructure work group has had a largely programmatic focus on making testing more available, which has involved multiple initiatives, including expanding mobile and walk-up testing sites, protocol development that facilitates contact between Medicaid providers and test-positive patients, making testing information and resources more available to limited English proficient communities, and implementation of neighborhood testing strategies working with community partners and organizations, among many others. The other work group that Lieutenant Governor formed has been called Primary Care Connections, which, like the lab testing group, has been the other early focus of the Racial Disparities Task Force. This work group has undertaken a number of initiatives to improve access to primary care health services, including developing recommendations for standardized provision of care using community health workers to connect individuals with needed resources in their community, and not just limited to medical care, but also housing, food, insurance enrollment, transportation, and other critical areas of identified need. Generally, the task force members have been asked to self-select into these work groups that best align with their expertise, their experience, and their interests. And as you mentioned, David, just within the last week or so, the Lieutenant Governor has asked the task force to expand our work groups to include 4 new ones in telemedicine access, corrections reform, environmental issues, and workplace protections, prevention, and resilience, although those 4 work groups are literally just getting underway. I think my time's almost up, but I'll wrap up by saying that the group thus far has been heavily focused on program implementation, which makes lots of sense given the acuteness of the challenge, and it really hasn't had the opportunity, I don't feel, of evolving to the point of either developing or connecting fully with research expertise and capacity. I've had quite a number of faculty colleagues across campus send me their papers and their technical reports on racial disparities, again, from lots of different academic units, all of which I forward on to the task force, and it represents an impressive body of work, but I think largely at this point has not been fully digested or used to inform our work. I will say that I think that we can and will change as the group matures, but we're not quite there yet. Finally, I'll also to say that the governor, under the governor's original executive order, the task force will continue to exist until 90 days after her emergency order expires, although Lieutenant Governor Gilchrist has made it clear that they're hoping the task force will serve as a springboard to a more sustained and longer term effort in the state to address racial disparities in health. And finally, I'll just say that I think one of the reasons I was asked to serve on the task force is I previously served as the governor's chief medical executive of the state health department under Governor Granholm, and I was also the lead epidemiologist, so led the state response to SARS, West Nile virus, the anthrax mailings, a number of crises. And I'm struck, as I told the task force, I'm struck that we talked about many of the same racial disparities at the time, and it's now almost 20 years later, and somewhat discouragingly, we really have not made that much progress. Encouragingly, though, I think there's a new energy and interest in the current administration in terms of seriously addressing these disparities that really have plagued our healthcare system for many, many years. Thank you.
Thank you, Dr. Bolton. And that it's important for us to hear from our community. So I'm going to ask Reverend George Waddles and Alfreda Rooks to join us.
Good afternoon. I wanted to, and I was waiting for Alfreda to come on, but I wanted to say a few things about community engagement, which we plan to talk about together. Are you there?
I am here.
Okay, go ahead.
So good afternoon, everyone. And David, thank you so much for inviting me to be part of this, to talk about Michigan Medicine's community engagement. The department that I am in, Community Health Services, is our outreach arm of the institution. We have programs that are outward facing and what I term community anchored that address the needs of the community on a social determinant level or social needs such as housing, food, and access to medical care. Those programs operate in Washtenaw County, as well as our school-based health centers operate in Genesee County. Additionally, we provide in the winter months and the fall season, we provide the flu shot and wellness clinics at faith-based organizations, community centers, anywhere where we're needed. We even go to migrant farm camps, looking at those populations that are underrepresented and underserved in order to be able to provide access to care, again, addressing those social needs. As an institution, we support working on our community health needs assessment that's done out of my office. And we recently finished our second community health needs assessment done in partnership with St. Joe Chelsea and St. Joe Ann Arbor, the county health department, as well as with support from the Washington Health Initiative. We are coming on the tail end of our last implementation plan, where as an institution, we decided that we would invest money, nearly $9 million into community by reaching out to community-based organizations who are on the front line of servicing community to say, what is the best way for us to address these priorities of mental health, substance use disorder, obesity and related illnesses, and preconceptual and perinatal health. And we have seen some great success with that. It's not enough time to go into that today. But one of the most important things that I think that we do as an institution and out of our office is that we listen to community members, we engage with them, we talk with them about what their needs are, and then we bring back resources from Michigan Medicine into the community to address those needs. But more importantly, we also bring back the information from community, what they share with us, to be able to address both internally and externally how we provide services within our institution. And so with that, I want to leave some time for Reverend Waddles to talk.
All right. So thank you so much. And I appreciate very much our partnership together and how we have worked together on different things. One of the areas that we specifically work together on is the Washington Health Initiative. And some of the things that we started seeing initially caused us to want to partner even closer together. And that was, we started seeing issues around food disparities, food insecurity, housing insecurity. And so we started talking about what can we do. Our church, which is Second Baptist in Ypsilanti, and many other churches, and I'm going to mention some specific churches that did specific things. Reach Church helped with medical supplies. Bethel AME helped with making sure that people could purchase things that they needed outside of what was available. Ypsilanti Seventh-day Adventist Church, Messiah's Temple, Hope Clinic, all in our area made sure that we did everything we could to make sure that there was not food insecurity. But one of the issues that we started seeing was when people were hoarding food, food distribution and food banks in our area were having a difficult time. So we started conversations about what's going on, and then our partners at Washington Health Initiative Steering Committee as well, and partnering with food gatherers, were able to overcome some of those hurdles, as well as provide, there were some grants and things that were provided to help people with medical supplies. Let me tell you one of the things that was interesting: food, shopping carts, because people have to walk to buy groceries. And then another was issues with the AATA, not allowing people to carry more than 2 bags of groceries on public transportation. That was a big thing that got settled. And so in our communities, and 48197, where our church is located, was hit pretty hard with the coronavirus. Field directors which we interface with all the time, were telling us that they could not almost handle the number of deaths that were occurring in our area. And so we thank Alfreda and her team for partnership, because it made sure that people's needs, real felt needs, not just healthcare needs, but life needs. Let me also tell you that there were pop-up clinics and testing at Park Ridge Community Center, in Willow Run, at Perry School, Bethel AME, and those were direct result of our communication and our partnership. And so we're grateful for that, as well as the partnership that we had with Sheriff Clayton and Derek Jackson and Friends United to make sure that people were being taken care of and their needs were being met around issues of housing insecurity, food insecurity, medical supplies, and so forth. So those are the things that we saw that were important. Of course, it's also important that the way people are engaging with the healthcare community is important. And so we are grateful for Michigan Medicine's commitment to making sure that people are treated equitably and fairly. And that's my 2 cents.
Okay. And so in response to what Reverend Waddle said, listening to community is very important. And that is one of the reasons why Michigan Medicine ended up partnering with food gatherers. And at the same time that people were bringing medical donations and PPE donations to Michigan Medicine, they were also able to bring food for food gatherers. And that has been a very well-received and well-supported project from community. That is how we were able to make sure that food banks and others places could have the food that they needed. We will continue to listen and talk to understand what community needs, especially as we go into the fall planning. We know that there's a possibility of a second surge, and we want to make sure that folks have access. And so again, thank you to Reverend Waddles and other folks in the community who talked to us, who came to me and others at Michigan Medicine to express what the needs are. So thank you.
Thank you both. And Frida does great work. However, we can still do more, and we look for opportunities to do more for our community. Next, I'd like to welcome Dr. Paula Lantz. She's going to talk to us about how policy, practices, and procedures contribute to disparities.
Great. Thank you. It's really an honor to be with all of you today. I have a very big topic I've been asked to talk about in a short amount of time, and so I'm admittedly relying on the crutch of slides to get through all the important things I want to say again in this short period of time. So we all know that inequities related to COVID-19 are fundamentally related to inequities in who's exposed to the virus, who's tested, who ends up getting the disease, who experiences serious and ongoing illness, and then who dies from the disease. And we also know and are not surprised by the fact that all of these outcomes related to COVID-19 are driven and patterned by the same social determinants of health that produce all other health disparities that are well known and have been well studied for decades. So in policy, of the many, many social determinants of health out there, policy, both public policy, but policy at other levels, at institution levels, business levels, et cetera, are really important drivers of both health and health inequities. And policy operates at 3 different levels. It does operate at the micro level, within and between people. Policy operates at the meso or neighborhood and community level, but policy also is extremely important at the macro level, fundamentally driving institutions and systems, including institutions and systems of discrimination and racism. So we can ask the question, why are African Americans and other communities of color experiencing worse outcomes from COVID-19? And the answer is not simply because they're less able to avoid exposure because of their jobs, or because they have higher rates of high-risk chronic conditions, and some of the other explanations that are floating out there primarily in the popular press. And also the answer is not because of race or social class. The answer really is because of the macro level social determinants of health that drive the distribution of socioeconomic resources and power in our society. And this includes systemic racism, institutional discrimination, and the marginalization of communities, all of which are driven by and reinforced through public policy. So again, this is a big topic, and actually last week I was a co-author of a paper that got published in the Journal of Health Policy, Politics, and Law, where we try to address this big topic from the point of view of thinking about pandemic preparedness and rapid response through a health equity lens. We start this paper with this statement here: COVID-19 pandemic has set in high relief the entrenched health, social, racial, political, and economic inequities within American society, exploiting decades of structural inequity to disproportionately strike historically marginalized and under-resourced populations. And this includes inequities in wealth and education. It includes inequities in who has health insurance and who doesn't in this country, who has paid sick leave and who doesn't in this country. It's related to the affordable housing crisis in this country. It's related to systemic drivers of unemployment and underemployment, the deep underinvestment in inner cities. It's related to environmental racism, and it is related to the carceral state. So, and also tragically, we have to recognize that the necessary public health interventions that have to be implemented during an epidemic or a pandemic also exacerbate racial, social, and economic inequities. Stay-at-home orders and other emergency public health interventions, while necessary to get the virus under control, also create huge hardship on people. So in our paper, we're arguing for a health equity framework for pandemic preparedness that's grounded in community engagement, that recognizes these fundamental causes of the social and health inequity, and also has a very clear focus on both the upstream policy drivers of inequity as well as the policies involved with rapid response. So there's a long list of things that we could talk about, and here are some of the things that we do talk about in the paper. So if we're going to be prepared for, again, a second wave that I think most epidemiologists, myself included, are pretty sure is going to happen, second, third, additional waves of this, and then perhaps there's other pandemics that are along the way. But again, this points to every sort of health inequity that we see in our society. We need public policy to better, first of all, ensure all the material conditions of health, which are food security, housing security, affordability and quality, air and water quality, physical safety, which includes policing, policy, and procedures. We need to ensure the basic economic security for individuals and families. We need to ensure financial and physical access to quality health care, and also access to technology for information, homeschooling, personal financing, including banking and voting, I'll say, and also access to technology that gets people public benefits that they deserve and are in need of. And then also additional investments in a strong public health infrastructure are an important part of a policy approach to health equity. Again, my main point today is that public policy, we need to look to policy change to help address the inequities that are, again, in full view through the COVID-19 epidemic. But also in doing that, we have to understand that public policy is also the fundamental problem. So it's both, can look at it both the savior, but we can't make policy change and have it really address those fundamental macro problems unless we understand the role that public policy has created in driving inequity in the first place. Thank you.
Thank you, Dr. Lance. You covered a lot of ground in a short period of time. Next, I'd like to welcome a panel on institutional and systemic racism. This will be moderated by Loretta Thomas, who is the former Chief Human Resources Officer at Michigan Medicine at one time, before it was Michigan Medicine, at the University of Michigan. And the panelists include Dr. Tabby Chavos, Dr. Fiona Lee, Dr. Lynn Vedeka, and Maria Thomas. Thank you.
Thank you, Dr. Brown, for the opportunity to be part of the Foundation for Future work that we all need to do together. It is certainly a pleasure and privilege to be able to moderate this panel of esteemed friends and colleagues that have been engaged in this struggle for a period of time. They've all been introduced, and so we will begin the discussion. Dr. Lance, your comments lead right into further work that we'd like to gain the perspectives, the experiences, the knowledge of our panelists on. So our first question to the panelists is, can you define structural and institutional racism and provide more examples for us so that we can understand what this looks like and feels like when we see it? Dr. Chavez, would you start with, can you define structural and institutional racism and give us some examples?
Yes, thank you, Dr. Lance. I think that was a perfect, as Rita said, that was a terrific setup. There are whole programs of scholarship across different disciplines dedicated to this concept, so I'm going to try to do it brief justice here. And for this discussion, I'll offer a definition that defines structural and institutional racism as policies and practices that systematically disadvantage and exploit Black people and other people of color. What is critical here is that these systems go beyond a particular individual or individuals, although such structures and institutions may serve as basis for people with racist beliefs to thrive and or to reinforce or socialize racist beliefs to those entering the systems or institutions so that those systems perpetuate themselves. Systems are really good at reinforcing and repeating themselves, and they're really resistant to change. A salient example, and I'll provide a few examples and then I'll throw the baton to my colleagues for a lot of the rest of the discussion, is anti-Black police violence. So that's a very salient discussion now. It's less productive or accurate to think about this as focused on individual bad people, the bad apples, although the perpetrating individuals do need to be brought to justice. It's more accurate to think of police systems and the training and the socialization and the culture that make up the system. For example, training standards and norms are uneven. They often emphasize combat defense approaches and an orientation of police as warriors against people. In contrast, there's often little training on conflict resolution, community relationship building, or training that grounds our police force with an understanding of the historical and current racial and social class inequality that can contribute to community challenges for the communities they work within. My apologies for my dog. Such a system is more likely to result in Black communities being viewed as other, deficient, or culturally impoverished, as less human in ways that may promote and legitimize non-human treatment, such as what we've been experiencing or observing in national media recently, but that is not new. This is why good people can participate in such a system, including individual Black police force members. I will say that this was really a critical point as I talked through current events with my young nephew who participated in Washington, D.C. protests. He noticed the presence of white and Black police officers who were acting in a similar dehumanizing way, and that was very jarring to him. And talking through this and helping him understand that this is a systematic issue helped him move away from solutions focused only on individual police members, and also helped him think about how he could be a part of a broader change strategy. Another salient example that I think Dr. Lance alluded to, and many others who preceded me today, is the topic of racial health disparities. But I want to focus on the interrelationship of wealth and residential discrimination, wealth and residential segregation in this country. White families have 20 times more wealth than Black families, and this pattern holds even when comparing Black and white families with the same income. What has contributed the most to wealth in this country? Home ownership. Well, structures such as the GI Bill following World War II infuse wealth into the middle class, the white middle class, by providing white veterans with funds for home ownership, tripling rates of home ownership in the subsequent decades. But the policy and its execution barred Black veterans from receiving those funds. Those policies, coupled with other discriminatory housing policies and redlining, led to segregated communities. And of course, in this country, separate is not equal. Black communities then had less access to capital for reinvestment once their spaces were defined as lower quality and risky, leading to further deterioration. This relates to unemployment and employment opportunities, lower quality education, which is funded through the local economic base, creation of food deserts, as groceries and other businesses are unlikely to invest and be present in those areas. And such communities are more likely to be subject to environmental toxins, such as the Flint water crisis and other similar situations illustrate, which undermine individual and community health. So multiple structural institutional forces interact to create conditions for racial disparities. And these are just simplifications of a more complex history. And finally, before passing the baton to my colleagues, I will highlight that a particularly insidious aspect of structural and institutional racism is that these structures present themselves as neutral or based on merit, but they are actually very racialized, and they're designed to result in more negative outcomes for Black people and people of color, such as lower educational and economic attainment, more incarceration and death in the legal criminal justice system. And when those negative outcomes happen, with injury added to insult, these systems try to convince individuals from the affected groups that they are the problem or at fault, and thus by extension, members of that group are the problem. The final example here is education, which is in my wheelhouse. Our pre-K through 12 educational system is based in residential segregation. And schools are actually more segregated now than in the post-segregation busing era of the 60s and the 70s. Given what I've noted before, what does this mean? This means schools in Black communities have fewer resources. And research shows that by any metric of teacher quality, schools with higher concentrations of Black and brown students have more teachers with lower quality indicators. Yet selective college institutions don't account for this inequality and use metrics that they think are neutral or based on merit, that are entangled with race and class. For instance, high schools are rated based on quality, such that applicants from weaker schools can be disadvantaged despite their motivation or merit. A student making an A in a quote unquote weaker school may be assigned a lower value in admissions than academic achievement, than an applicant from a stronger school who makes an A or even a B, despite the fact that the A student from the weaker or more disadvantaged school showed high motivation and worked to take full advantage of what that school had to offer in making an A. Similarly, admissions test scores are used, or rather misused, as a neutral indicator of merit, ability, or potential for college success. However, the biggest predictor of, for instance, SAT or ACT scores, the biggest predictor is one's zip code. If it were actually neutral, or a simple merit or capacity issue, we would not see differences based on zip code. So those scores are actually very bad measures of individual capacity or potential, but very good measures of structural inequality and structural racism. Again, a common thread is that these systems go beyond individual actors or decision makers. This makes solving the problem as a more complex task than a focus on changing individuals. And it means that we need people working to tackle different parts of all of these systems. That means all of us. I'll pass it on to my colleagues for further comment and elaboration.
Thank you for outlining the overview and broad perspective. I'm going to move on to the next question because I think you've done the big picture, and asked Dr. Lee if she would respond to what do you feel is the greatest policy or practice in healthcare that inhibits African Americans and other marginalized people from thriving in our society?
Well, thank you very much for including me in this panel. One of the things I actually want to talk about today is sort of related to another non-health related outcome that shows up in racial disparity, and that is with anti-Asian hate that has come up with COVID-19. And again, when we know about some of the discrimination and bias incidents targeted towards Asian Americans and stereotypes of Asian Americans bringing in the virus into the US. And like what Dr. Shaver said, this is not exactly just thinking about it as bad behavior from a few individuals, but really grounded in the cultural stereotypes of Asians as outsiders and as homogeneous and all the same, and without differentiating between different groups and different subgroups. And some of the examples that we have seen this is not only anti-Asian hate that has come up with COVID-19, but we have seen this in other situations as well. So for example, something that's also very, very current is sort of restrictions of international scholars, and especially scholars from China, revoking student visa or making it difficult for them to come to the US. And again, this reflects the stereotype of Asians and Asian Americans as outsiders, and that they are all the same. So regardless of what they have done, what institutions, what research they have done, setting policies that really restrict their involvement in the scholarly work and in our universities and higher education generally. So these are sort of other outcomes that are they're not health-related outcomes, but also reflect this type of racism, structural racism that we see in our society.
And we certainly understand that structural racism can impact health outcomes because of the impact on the people. Maria Thomas, would you like to comment on greatest policy or practice in healthcare that inhibits African Americans and other marginalized people from thriving? Ali, we would ask for your help. We cannot hear Maria. And while we work on solving that, I'm going to turn to Lynn Videka. Dean Videka, would you comment on that same question, please?
Yes, the greatest policy or practice in healthcare that inhibits African Americans and other marginalized people from thriving. I'm going to quote a study that was done by Elizabeth Bradley from Yale University School of Public Health and her colleagues. It was a World Health Organization study that looked at health outcomes of nations around the world, and many of you probably know that the United States does not rank among the best in the world with health outcomes. We're quite mediocre, actually. And what this group found was that health outcomes depended primarily not on the amount of money that was spent in healthcare, but rather social service expenditures. And it was the countries that addressed many of the domains that Paula Lance talked about: housing, income support, nutrition support, integration of people into the full community of the nation. Those were the factors that influence health outcomes. And because Black Americans are excluded from many social programs and have less access to socio and economic success, that directly affects health risk for that population.
Thank you so much. We have just 2.5 minutes to wrap up, and we want to help support the call to action. So our final question is, what are some best practices or research interventions that you have seen be successful in other academic-based institutions to break down some of these structures that appear neutral, and experiences that you may have had? I will ask Dr. Videka, Dean Videka, would you comment on that, please?
Yes, I will. I'm going to quote another study here. It's a literature review of 39 different empirical studies that looked at what practices produce better outcomes in health systems. And 32 programs showed positive effects. And here are there's no single magic bullet, but here are some of the interventions that made a big difference. Housing programs or housing coordination programs, helping people get out of the hospital into stable housing. Income support programs, nutrition support programs, care coordination programs. And this means multiple professionals working together. And here I want to give a big shout out to Michigan's interprofessional education program, because that's the kind of training that helps professionals work together for better health outcomes. And then finally, community outreach, and we heard a lot about that in this session also. We have the tools, we just need to put them to work, to paraphrase President Obama's statement the other day.
Thank you very much. Maria, I see that you are with us again, and we'd like to give you the final word on what, any comment on any of the three questions, because they're all very important to us.
I hope, can you hear me now?
Yes.
Excellent, yes, okay. So sorry about the technical glitches, and I so appreciate all of what the panelists before have shared. And I will say this, which is, we do a lot of theorizing about the structural racism and institutional racism from a remove. And I think part of what is critical to this work is making sure that we are self-reflective and analyze what our own institution and the structures within it might perpetuate. And so I'm the director of community benefit and community health needs assessment. And
I'm sorry, that was my timer, that we are out of time.
Oh,
So could you just wrap up your thought?
yes, yes, absolutely. So we see things like housing, poverty, and incarceration being some of the main drivers of those inequities. But I think we need to interrogate how, through our endowment policies, we sometimes perpetuate these things because we continue to invest in fossil fuels when we know that hastens harm to our planet and our people. And then we also invest in private equity funds that actively unhouse folks and add to rampant gentrification when we also do address those through some of the investments that we have that we should be proud of. We need to address the negative externalities of some of our actions. And I really appreciate Dr. Chavis's point about anti-Black violence and police brutality in this moment. We have to name that. And I think this is a time when we should interrogate, as an institution, our own relationship and investment in campus police and police in general. And I'll end with some evidence from the American Association for Public Health, which has a whole policy statement that is based on evidence about how to end law enforcement violence. And their recommendations are crystal clear. It is about decriminalizing activities shaped by the experience of marginalization. So we're talking about things like substance use, minor traffic violations, sex work, right? Broken taillights. These things need to be decriminalized, and reallocation from funds from policing to the social determinants of health that Paula mentioned has to happen in order for harms to be prevented. And so I think the main point that I'll end with is this: evidence alone is not enough. And there's a difference between research on racism and anti-racist research and practice that elevates movement demands for structural equity and justice. And that's what I hope we will all have the courage to name and institute institutional fixes for, knowing that sometimes naming the problem will cause us to be named the problem, but name it we must if we are to diagnose and accurately fix it. And I'll end there. Thank you.
Thank you to all of the panelists, and I believe our audience have all heard some aspect of this very deep-rooted problem situation that we can take personal action on. Back to you, Dr. Brown.
Thank you. Thank you to this panel. Each of you could have probably spoken for a full hour. We only have a few minutes left, and I do want to hear some words from our executive leadership, Dr. Marshall Runge, Dr. David Spollinger, Dr. Carol Bradford, Dr. Stephen Kunkel, Dr. Mike Mulholland, and Nancy May. We did receive questions from you, and we will try to answer them if we don't get to them today in an FAQ. If you have other questions that you want to put in the chat, we will try to address those as well. I'm going to ask just one or two questions because of the time. First question for anyone: what is leadership's commitment to healthcare disparities, and how do you plan to build trust with the African American community within Michigan Medicine and outside of Michigan Medicine?
David, this is Steve Kunkel. I'll take a first stab at this one. Actually, there's two parts to this question that are really connected. As trust is the foundation that all relationships are built upon, whether they are professional relationships or personal relationships. And without trust, our commitments will ring very hollow. So I believe that trust is one of the single most essential elements for building these relationships. And I'd like to speak to a research area that addresses a commitment to the African American community that is really built on trust, and that is our collective efforts in the Michigan Medicine towards clinical research and clinical trials. Conducting human participant research is always a partnership between the population being studied, the researchers doing the study, and the entities that actually review this research. And I'd like to underscore the important role of the Institutional Review Board, who makes sure that our studies are done ethically and safely. And given the importance of our research mission at the University of Michigan within the state and across the nation, it's important that we encourage studies that seek to enroll diverse participant population, including African American communities. Creating trust within these communities means not only addressing the health disparities through research, but being sensitive to the community's attitudes, the participants' needs, and the protection of the participants. And all this is done under our institutional review boards here at Michigan Medicine. Thank you, David.
Thank you. Anyone else want to address that question as well?
So I think that Elfrida said partnering with the community and listening to the community understand their concerns is a significant part of our building trust with the community. I think it's also important for us to have a commitment in our executive priorities to trying to reduce health disparities and to publish our outcomes and make those transparent in different health equity, outcomes. What is the different percentage of our populations that are receiving screening? Are different approaches to care being provided to the different populations? We are just beginning to measure that, but it is becoming part of our dashboard, and we want to make that transparent, not just to our internal leadership, but also to the community as a whole, that we are trying to address that. I think the other area we need to think about is addressing or highlighting some federal policies that actually impede solving some of these problems. Earlier, they talked about health coordination programs and income support. All those are violations of the anti-kickback laws within Medicare and Medicaid. And so some of our supports that we've provided in the past have been deemed illegal under that law, and we need to highlight that as one of the structural elements that continue fostering health disparities. Thank you.
Thank you. And when I announced everyone, I didn't call Dr. Nancy May, so I apologize for that. But I want to give our last three panelists opportunity to respond to that question or anything that they feel within their power that they can do to help eliminate healthcare disparities here at Michigan Medicine.
So I'd just like to say that, we do a lot of screening for social determinants of health, and it's a screening tool, but what we do with the results of that is so important to manage the care coordination for our patients that we serve. And we are embarking with a grant through Blue Cross Blue Shield right now, where we've hired some temporary social workers to go in and actually into our ED to really look at social determinants of health to see if we can put programs together. Many of the programs that we already have in existence and help those in need. And so I think not only does our social work department as well as our nursing department play a pivotal part, but it's really about listening to what the needs of the patients are. And we heard over and over and over again from many of our fine speakers today that really listening to the patients and their needs and how we do community assessments for those needs and put services most appropriate to the needs of the community is important moving forward.
So I'll comment briefly, and I'm going to take the tact of looking at our educational programs and our faculty. And I think that we have all learned that we really must both educate and inform our learning community on social determinants of health and healthcare disparity and how to treat one another with respect, and to make sure that all of our hiring practices are foster inclusion. And I look to our people pillar of the medical school strategic plan, where we really focus on diversity, equity, and inclusion in all elements of our people strategy, our recruitment efforts, our retention efforts, and our promotion efforts. And so I think there's a lot to be done. I think this has been an incredibly informative hour. We've all learned a lot. But I actually also commit to this entire audience that we all need to collectively examine our policies and practices that are in place today and see to ensure that all policies are anti-racism policies, and that is all of our education, all of our faculty, and all of our strategic planning processes. Thank you.
Thank you. And Dr. Mulholland, I'll give you the last words in this panel.
Thank you. So I would just say we need to be sure that good ideas don't make disparities worse. Virtual care is a great example. It's a wonderful program that could leave some people behind. And we need to be sure that we overcome those barriers and leave no one behind as we go into the future.
Thank you, everyone. We packed in a lot in this hour. We could talk about this for many more hours. I appreciate everyone's contributions and participating. Martin Luther King Jr. once said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Some of us take a Hippocratic oath to care for patients, and all of us have a duty to give the best care possible and equitable care. Let us all do our part to make healthcare justice reforms to achieve healthcare equity for all. With that, I'll leave it to Dr. Runge if you want to make any final comments.
Thank you all for being here today and for your engagement. This is critically important work, and we most undoubtedly have a long way to go. As we move forward, I'd like to comment on 3 important issues that I think we need to consider very thoughtfully as we engage our communities. The first is around communication and creating two-way dialogue. As we work to expand healthcare access, what is the best way to share information with communities that have been historically underserved? The traditional ways we talk about our services may or may not be effective, or may not resonate with specific communities and populations. Second, we need to take a hard look at our own attitudes about inequity and racial disparities. Are we unintentionally contributing to the problem? When patients come to us, are we doing everything possible to make them feel comfortable, respected, and heard? And finally, for any change that we're talking about to be sustainable, we must develop the right behaviors and then be committed to embedding these in our culture. We've done some good work around culture, but I think we'd all agree that our institution has a great opportunity to become a more forward-thinking organization about disparities. We need more systemic culture change and to direct that in the ways that have been mentioned today and we need to continue thinking about. So thank you again for all your perspectives. We all need to do more learning, community listening, and to better understand how we can improve healthcare access for all.
Thank you, Dr. Runge. Thank you to the participants and organizers and everyone for participating. We will have multiple forums because there's a lot to discuss and a lot to get through. We appreciate you participating and for your attendance. Thank you.